2 seconds. Jeepers, you're right about that, is small. I can play from the start on mine, but maybe. There we go.
Perfect. Okay, go ahead. Thank you.
Okay. All right. So thank you for having me today. I understand that all of your roles may vary in different contexts, but I believe this project exemplifies the importance of assessing the human investment needed to effectively coordinate care for children and adolescents with cancer. The background leading to this project stemmed from a poignant moment when a family referred to me as their Mary Poppins. This whimsical reference encapsulated the enormity of the role of a paediatric oncology nurse consultant and really made me think. So this is my story, addressing the elephant in the room. We all sense the tension at work, but shy away from discussing it or comprehending its origins. This scenario has recurred numerous times throughout my 35-year career as a paediatric oncology nurse. In March 2022, I encountered this struggle once more. I recall the day vividly, as well as the events leading up to it. The perpetual stress took its toll, manifesting in physical symptoms. I found myself darting from one patient to another, juggling meetings and feeling constantly pulled in different directions due to the overwhelming demands. It became apparent that my role was no longer manageable for a single individual. The pressure had become unbearable. I'd reached my breaking point. It was imperative for me to take leave. I was burnt out. However, this time I wanted my colleagues to understand the underlying reasons, and what I also wanted to know what was behind it all. So the objectives of this project were to quantify and understand the workload demand on the Children's Cancer Centre CNC, and particularly myself, to understand the problems, to determine the causes, and did the capacity of the CNC meet the current demand? Where was the scope, and would benchmarking give us any answers or identify any solutions? So how did we do this? After 6 weeks of leave, I was offered dedicated time to work on this project in the Quality Improvement Department. This was a whole other world for me. This project was to collate and evaluate data relating to tasks and clinical responsibilities of a single CNC, specialising in solid tumours. Process mapping, flow analysis, and time and motion studies were conducted for new, active, and off-treatment patients from January 2017 to May 2022. So we started listing and identifying what is currently expected of the solid CNC, to be the co-manager, to be the expert, to be present at key discussions, to give family education, to coordinate all of the multidisciplinary care, the keeper of the roadmap or treatment journey, co-advocacy for the patient and family, noting the job description had been written in 2017. There had been lots of changes that had occurred across the board with the introductions of our electronic medical record and COVID during this time. But what else happens? There are mandated meetings, approximately 6 per week, incidental meetings, additional tasks such as COVID issues, surge meetings due to lack of bed access, rework due to delays, and pick up work when the colleagues are on leave, and also incidental work. A central part of this project was process mapping. My mentor was Simon Lane, the Improvement and Capability Advisor for the Quality Improvement team at the Children's. He knew nothing about paediatric oncology. He worked in the hospital, so knew the difficulty we had with lots of processes, but didn't really understand the nitty-gritty. He guided me through the steps we needed to take to understand the problem. We started off with this map to understand how the unit was staffed, brainstorming to break it up into identified areas to study, identifying everything I did in a day and what was involved, and that we then used the problem matrix to determine the problem causes and symptoms, so the PDSA. What we know generally is there's incidental work in most jobs, in most nursing jobs, which looks like this. Studies of nurses in the NHS hospitals in Britain have shown this non-added work value in all areas of work. There is a huge amount of time in walking, waiting, reworking, and unplanned conversations. This is a bit of a busy slide, but we know there is wasting work, but that was difficult to quantify. So how did we do this? We began by looking at the job description and roles and responsibilities. We identified tasks done by the CNC and then the approximate time taken to complete them. We then collected real-time data for these tasks. This was done over a 20-day period as a snapshot, a task cycle time data collection. I then put these tasks into a table showing what is done by the CNC and what could be picked up by other roles in the future. What we found was the patient care workloads varied with demand, and clearly one EFT did not fit. There was overburden. I want to visually tell you the story now of the average CNC day to then try and understand the programmed demand and where it is. This is what the calendar looked like in 2017. This shows the program work going on throughout the day, most meetings being 1 to 2 hours. This is the calendar now. Extra meetings are added over the years, adding more demand, noting the crossover throughout the week. So what else happens in a day? And where is the demand physically? Noting each day is different. This is where the patients are. This is just one example in 1 week. The number of patients required to be seen in the clinic varies according to the treatment and their needs. Similarly, for the ward patients, note there are multiple consultants in clinic at one time and the ward round is running concurrently. We can't see all the patients required in one day, so what takes precedence here? So the catch-up, as you can see, is often via email and phone after hours. We then process map the individual workflows to better understand how they worked, what the problems were, and the time they took per patient. The following is only one example of the 6 that I mapped. This is to visualize how the process works and the average time taken for each patient. This is a time for planning 1 patient in clinic. Note there are several at one time. The Solid CNC, so in this case myself, has an average of 80 active patients at one time. The CNC reviews all the active patients' treatment ahead of time to ensure bookings are in place. On the day, is the booking in place for review? Is the day oncology or inpatient booking made for treatment? Is the hospital in the home referred if needed? Is there a blood test prior to clinic or is it done externally? Tracing its bloods takes time. Is the patient ready? No. Defer and replan. Yes. Is the chemo ready? No. Replan. Yes. Proceed. Is the bed ready? Yes. Proceed. No. Replan. So there is often a lot of unplanned work that arises through the processing of one active patient. Consider the difference to rework if the bloods are done and collected 2 days before appointments. The admissions can then be better planned as the bloods are known earlier and changes made accordingly. If blood's done ahead of time, the admin staff can chase these. This average time for chasing these bloods can take 10 to 20 minutes, so likely to speed up the clinic review. Chemo can be ordered ahead of time. There'll still be admission roadblocks, which we need to consider, but we could start to consider other options, such as prehydration stations in the day oncology, if waiting on discharges later in the day is an option. Also, the use of chemo in the home has begun to grow a lot more for us. These interventions have all been instigated in our unit over the last 12 to 18 months. I then looked at patient demand and numbers. I started this by collecting a snapshot of data from 2020. I also looked at the census from 2021 and 2022 to look at the spread across the hospital, noting that we can have up to 61 inpatients at the highest demand all over the hospital, leading to extra time in walking and increased workload. I did a quick look at deferrals, as there's been no standard data collection in place for this, which has become an increasing problem affecting our workload. The lack of data collection for our unit became obvious to me from this point. There was no easy way to pull the data easily. There was no visibility. I looked at the clinical staffing, considering how EFT affects the CNC workload. How many consultants in clinics at one time? How many are part-time? How have the other craft groups changed and affected the CNC workloads, for example, social work and the clinical trials? Noting that these numbers have already changed hugely following this project. In recent business cases, our figures have shown there to be 400 to 450 new patients per year for our unit. I wanted to show the breakdown of the streams, particularly the solid stream, which was my stream. This data has been pulled from the first admission under oncology. When pulling this data, again, it was difficult to determine whether some diagnoses were actually oncology related. This is shown by the yellow line. Again, the data is not entered consistently or easy to find in the EMR. However, this snapshot did help to show me that the liquid and solid streams were becoming similar and that the current CNC staffing was not allowing for this increase. The average for solids was now 77% and liquids was 83%. So you can see the comparison. I looked at the clinical trials. Again, this data was difficult to collect. Whilst this data is a few years old, I think it's important to know the information because the trial patients do contribute to workload across the unit as a whole, not just for nursing, but for social work, for day oncology, for hospital in the home. This number has now tripled since I started this project. I wanted to look at the numbers at these figures because the number of palliative care patients can also have an effect on our workload. We are working alongside the consultative service. We are often considering other palliative treatment options or trials. There is extra planning and education that goes with that, as well as the increase in emotional psychosocial support and demands from the families in this cohort can be immense. I then did some benchmarking around paediatric oncology centres in Australia to understand what other CNCs experience with this work. What does it look like for other centres? Unfortunately, again, this wasn't as helpful as I'd hoped. I had 27 responses, many being incomplete. What I found, though, was many CNCs operate very differently from being stream-based to looking after mixed tumour groups or solely outpatient-based or inpatient-based. Again, the data was not very accurate. But what this did show is that we were one of the largest centres in Australia. We have several new initiatives with the development of other programs. We have many more clinical trials open, which does have a knock-on effect to all areas of staffing in the CCC. The actual CNC staffing in our unit seems lower comparatively to the total patients in our centre. Perhaps this data will grow further into a research project around staffing and mental health for paediatric oncology CNCs throughout the Australia and New Zealand oncology group in the future. I then pulled the data on my own personal communications with my patients and families. This is a huge part of the CNC work. The fluctuation is due to periods of leave as well as changes in patient numbers and demands, but it shows the data being anything from 5 to 30 per week. This involves communications via phone, email, and the work that goes along with that. This slide was attempting to estimate the total workload each week across the entire period. This was done to visualise the hours of work required to compare to those scheduled, 40 hours. We did this by adding together the time estimates of various components that make up the workday of the solid tumour CNC as documented on the slide. The program work is in orange. That's the fixed hours per week, meetings and things on the calendar. Program breaks is yellow. The demand work is blue, and this variable hours per week. This was estimated by taking a standard time estimate for each type of demand work and multiplying it by the number of times this work is done in the week. For example, the time estimated to start a new patient times the number of new patients in the week. The black line and pink markers is the total of them all added together. Program, patient demand, incidental work, waste, and breaks. This graph clearly shows workload wildly fluctuating and fragmented, mostly greater than 40 hours for many weeks in a row. So as you can see, 50 to 60 hours per week and 40 to 50 hours per week were logged at 21 and 51% of the time on this study. Obviously, unsustainable, unrealistic workload leading to burnout. So in summary, what did I find? I found overflowing workload. This is what it feels like. No space to breathe, no time to process the emotional impact of work, no time to regroup between tasks, no space for research or further education opportunities, and often the work is totally undermined and invisible due to poor data entry. The data didn't show increase in the number of patients, but it did show wildly fluctuating workloads leading to burnout. This is how it should be. Breathing space. Quantifying workloads is a critical step in determining the human resources investment required to optimally coordinate care with children and adolescents with cancer. So what were the considerations for improvement from this project? To continue data Firstly, we need a realistic human resource allocation to meet the expectations to provide optimal care, looking at the staffing and EFT across the Children's Cancer Centre. Mostly, we need to implement a model of care that supports unpredictable and fluctuating workloads. The outcomes to date. The division of my role has now occurred by tumour types. This is my oxygen mask, and this began in January 2023. Ongoing quality improvement data collection has continued. We have developed mandated standardised smart forms for data entry across all areas of the electronic medical records related to children's cancer. We've increased the EFT for patient flow officers and administration support for chasing things such as bloods and answering family questions and checking on bookings. We have implemented a survivorship coordinator to look after the off-treatment patients. And we have dedicated CNC leave cover so that when I'm on leave, my job is being covered by other people. And of course, we have clinical supervision. I'd like to extend my heartfelt gratitude to Simon Lane, the Improvement Capability Officer from the Quality Improvement Department at the Children's Hospital, for his unwavering patience and enthusiastic support throughout this project. I am deeply appreciative of the Children's Cancer Centre at RCH for backing and encouraging me to undertake this endeavour, and I additionally am in debt to Sandra Staffareri for her mentorship and friendship. Quality improvement truly opens up a whole new world of possibilities. I encourage everyone to do some of it. Thank you.